Any comments, any questions, any concerns? Oh, you hit it.
Thank you for your presentations. I have two questions. First one for whoever willing to entertain it. What is the contribution of myofascial structures to low back pain? And if there are, how do we assess and treat them? And second one for Dr. Saeed, is there a case to be specific in terms of exercise prescription? Is there a case to prefer certain slings over others given specific diagnosis or patient presentations?
Yeah, thank you for the question, Alex. I will take the second one first. I think that in your assessments, in your subjective or your objective information that you're collecting in your evaluations and examinations, you're probably collecting the information that will lead you down to where you want to end up and get that patient at discharge, such as a patient who is a avid exerciser that is often a runner, for example, where most of the time you can probably argue that both the anterior oblique sling and the posterior oblique sling are being applied in a cyclical fashion. And so in that sense, your goal is to probably get them to that point. In your first question about the myofascial slings and having a source of pain, is that correct? Yeah, I think that there is an absolute chance that that is happening. One of the comments that I didn't include in the slides today, but there is a recent study in the last few years by a group, Catania, I believe, who's looking at how can we assess these slings as almost as a part of MMT, as what we do for individual muscles or individual movements. And I don't think the study was great in the sense that the positioning of the joints were such that would really reproduce what we would see in movement as a sling. So I didn't include it in this, but I think that is the next direction, to see if there's a way that we can actually assess these slings with what we do in the clinic, and then see if they might be reproducing a pain or dysfunctions that the patient is complaining about. That will then drive how we get that patient down to the discharge with reproducing those slings and interventions.
And to answer the myofascial part as well, if you look to the work that's done in Scandinavia, much more here in this country, because this country relies so much on commercial investment to do research, there's a lot of work that's been done on repetitive stress, on rabbit fascia and some other animals and so forth, and micro tears within the fascia itself as a source of pain. And so that work, there's a number of good studies out of France as well. And for the slings, I'd also, Andre Vleeming actually borrowed the term from Kurt Tittel. And so if you're looking at slings and the use of slings, the most kind of sophisticated look at that was Kurt Tittel, who worked with Olympic athletes in East Germany in the 60s and 70s and wrote some really interesting and meticulous, we'd name, the fascial connections and all these muscles and stuff, but I would Tittel, Kurt Tittel. I guide you to his work because a lot of what Vleeming taught came from Kurt Tittel, who did a really sophisticated paradigm in terms of that. Yes.
This is for Dr. Wenchi. With the mechanical diagnosis and therapy directional preference, when you are doing the assessment, how many times do you ask the patient to repeat the movement? And then the second question is, from your experience, how many percentage of the patients eventually need hands-on as an added force, as a force progression to the treatment?
Can you hear me? Yeah. Great question. Thank you. I just didn't have a lot of time to go through the whole process of how we go about it. But typically we would, when I am first assessing the patient, I want to look at baselines first. So I get a baseline of all directional movements first, and I record what the patient's response is. And typically we go by red light, green light, and yellow light. So if the patient has pain during the movement, but they're no worse after coming up, that's my yellow light that I can proceed, but proceed with caution. If they have decrease in their symptoms and their symptoms remain reduced or abolished, that's my green light. I can go ahead and keep going. But if that symptom worsens as they do their exercise, as they do that one motion and they come back up and they're worse than when they started and it doesn't resolve, that's usually my red light to stop. So based on that one motion will help kind of direct my treatment going forward. Typically, the motion you want to repeat about 10 times. And then after those 10 times, I gauge a response from the patient of how they're feeling. If their symptoms are greatly reduced, that's usually my green light to keep going in that direction. And I think the second question was
Santia, I think it's an interesting question. When
Yeah.
you read Robin McKenzie's book, Mechanical
Yes.
Diagnosis,
yes,
he does show specific manipulations,
yes,
right, in his text. Can you speak to when you would use manual therapy as an
Yes.
adjunct or the application of force?
yes. So when you see that symptoms have plateaued or they're no longer making any progression, that's usually when we would use some type of manual mobilization to help the patient achieve continued reduction of their symptoms. So if someone comes in and they say, my symptoms are getting better, but they don't stay better, my symptoms continue to return after I've done the exercise, that's usually when I want to use my hands to help progress the force to get them to the next stage to get reduction in their symptoms. So it's usually whenever their response is stalled or they no longer are getting progression in their symptoms is usually when we will reintroduce manual therapy.
To be clear, because I feel we all speak around the fact that we all use motor control.
Yes.
Right. So to be clear, after having then applied the manual therapy, I know from my take, if I apply the manual therapy, I don't assume that the patient now can function in the new range they may have imparted or in the new. So then you do go back to the repetitive motion
Yes.
in a larger range at that point.
Yes, we do. And sometimes too, the patient may come in and get reduction of symptoms, but they're just not lasting. That's usually when I would progress. If just my own clinician overpressure is not enough, that's when I would progress to the next stage, which is mobilization, going through the grades of 1 through 4 and getting the reduction that I want. Once I get the positive response that I'm looking for, then I want to see if the patient is able to maintain what I just helped them achieve. Did I answer your question? Yeah.
Is that answered? I think we're probably at a wrap. We're at 4 o'clock. Although I can't speak for Santia, but I'll stay another 2 minutes to answer a question. But I want to give everyone else it's been a long day. Thank you guys so much for coming. And let's look, this has been one way we've been teaching and you've been absorbing. I'm under no illusions that pretty much everybody in the room has something to teach us or to teach me. So please, if you would like to remain in contact at some point, please keep in contact. And some of you I see and I recognize from the pediatric conference and keep in contact with Prachi and with me and with Abby and with Carly and here all of us here is Columbia and also Cornell. And we'd like to keep